Well, hello, everyone. This is Dave Berta, news editor at Foresight Health. Welcome to today's Foresight Health webinar, Uncertainty, Margin Pressure, and Disruption, Forward-Looking Crisis Management During the COVID-19 Outbreak. If that doesn't scare you, I'm not sure what will. In a moment, Dave Johnson, founder and CEO of Foresight Health, will share his insights on how the COVID-19 outbreak has dramatically increased the margin pressures that hospitals and health systems were already feeling, and how leaders can think strategically to manage the crisis to position their organizations for future stability coming out of the pandemic. Now I will hand the controls over to Dave, who's been waiting patiently in the box below me to share his thinking on managing your margin pressures during and after the pandemic. Dave, take it away.
Thanks, Dave. Wow, lots of Daves on this call. The core thesis underlying this presentation is that it is impossible to understand what's happening now in post-COVID healthcare without understanding the forces that were already driving health system transformation pre-COVID. With that in mind, I've broken this presentation into two parts. The first is before COVID-19. This section will draw from an article Jeff Jones and I co-authored in January, so before all this happened, with the title Unrelenting Margin Pressure, Overcoming Healthcare's Softening Revenues and Rising Expenses. The second section is after COVID-19. Here I will detail why the forces driving transformation in healthcare are actually accelerating and what to do about it. In Hamlet, royal counselor Polonius tells the king and queen of Denmark, brevity is the soul of wit. I've always loved that phrase. So it is. I will strive to be concise, 10 minutes for each section with plenty of time for questions. So let's get to it. Let's begin by going back in time to the 1990s. This was the only decade where healthcare expenditure remained constant as a percentage of GDP. Basically, it went to 13.4% in 91 and stayed there for the entire decade. And the reason this happened was a mix of market pressures, remember HMOs, and governmental pressures, remember the Balanced Budget Act of 1997. They combined to rein in healthcare expenditures and in many ways upended healthcare delivery. They brought some health systems to the brink of insolvency. At the time, back in my investment banker days when I was paying a lot of attention to this, Moody's Investor Service created something called the Century Club, and the only thing you had to do to become a member was lose more than $100 million from operations. And unfortunately, there were very many members, large health system members. And then like that, the pressure evaporated as we moved into the new millennium. So what happened? HMOs faltered. I remember watching the movie As Good as It Gets down the street from where I live. And Helen Hunt, who won the Best Actress Award in the late 90s for that movie, gave a profanity-laden rant against HMOs and their treatment of her son's asthma. And the theater I was in broke into spontaneous applause. And that's when I knew HMOs were at or near their end. So there was enormous consumer frustration. There was pent-up demand. Fee-for-service returned with a vengeance. No more capitation or very little capitation. And the government, after having balanced the budget, became comfortable with deficit financing healthcare expenditures. That in turn led to a massive investment in acute care facilities. We had subsequent government investment in technology through the HITECH Act and, of course, the Affordable Care Act, which came into being in 2010 and expanded access. The byproduct of all that activity, that great 20-year run for healthcare, is that the industry's percentage of GDP grew from 13.4% to roughly 18% now, and of course it's projected to go higher. And that occurs because the costs are escalating at a faster rate than the overall economy. And when you look at things on a percentage basis like this, you can't get higher without taking away monies from other things. And healthcare obviously takes money away from a lot of other activities. And that's created a fair amount of frustration within society writ large at the industry's inability to deliver value. And we've been having a version of this value discussion seriously for at least 10 years. The Affordable Care Act was predicated on creating more value in healthcare, and it really hasn't happened. The conclusion of all that is, going forward with all this societal pressure on reining in healthcare expenditures, is that business as usual really isn't sustainable. And it will happen this decade in the same way that it happened in the 90s, through a mix of market pressure and governmental pressures. But in the article Jeff and I wrote, we identified 5 fundamental forces that are really putting pressure on health systems in a way that wasn't there before. The first is the shifting payer mix. As baby boomers age into Medicare, as more people get consumed by the Medicaid rolls, which is going to increase now with all of the unemployment, we go from commercial payers to governmental payers, and of course, government doesn't pay as well as commercial payers do. So just much more revenue softness on the top line by virtue of who's paying the bills. Now, the subsidies in healthcare largely come from self-insured corporations that are paying increasingly high premiums for healthcare coverage. Often as much as 2 to 3 times what Medicare is paying for services, and they're getting tired of that. And my sort of shorthand for discussing more disciplined purchasing is demand-driven change, superhero results. So McDonald's today is experimenting with kale salads, not because it doesn't want to sell you more burgers, it's because their customers are demanding healthier menu choices. In the same way, the corporations and the governments, and to some extent individuals that are buying healthcare services, are demanding more value, and they're figuring out ways to push that demand onto the health system writ large. Part of that is a big change in consumer behaviors, much easier to get information. With the increase in high deductible health plans, they're spending more and more of their own hard-earned dollars on healthcare. They want to spend those wisely. And so that's made predicting volume even before COVID difficult. We've seen, because healthcare is now such a big part of the economy, really the biggest part of the economy, entirely new competitors coming in, some established players like United Healthcare getting more and more into the provider business through its Optum, new entrants, even Best Buy, right, when it bought the Great Call, which makes the jitterbug phones with the big numbers. So we're getting new competitors coming in, and they're not trying to solve the whole problem. They're just looking for a segment of the industry where they can deliver more value. And given the large areas of inefficiency built into healthcare, there's lots of opportunity. And then on the government side, dramatically shifting regulatory environment, pushing transparency, pushing data sharing, pushing a level field competition. And then at the same time, on the operating level, health systems confront rising labor and supply costs, as well as these demands for more value. So that means, believing that you can cling to the old fee-for-service, transaction-oriented way of doing business is probably not sustainable long-term, and certainly not sustainable post-COVID, as we'll get into in the second section. So we're essentially in a new game with new rules. And Einstein said, when you're playing a new game, you have to learn the new rules and play it better than anybody else. So with that in mind, let's talk about the old game, which here we call old math, and the new game, which we call new math. In old math, revenues were largely flexible, right? You could always get paid more money. That's why revenue cycle is such a big part of the health system business model. Expenses less important, often baked into the payment formularies. The difference is margin. The managerial orientation is focused on getting paid, optimizing revenue, and so on. And that's still the way the vast majority of the industry works, probably 90+%. The new math, increasingly, though, will have revenues that are inelastic or fixed. Think about bundles, a fixed payment for a hip replacement, or think about capitation, for pop health, direct contracting per member per month. So that's fixed. In that sense, the revenues, there isn't much you can do about revenues. So the difference is managing expenses, which becomes essential. And as always, when you subtract expenses from revenues, you get a profit or loss. So the managerial orientation, the purpose of the company has to be on creating value. How can you take these fixed revenues, operate in such a way as to generate a profit and convince customers that you're providing value to them so you can sustain business? And that increasingly means delivering the best outcome at the lowest price. And the call to action, and this is the pre-COVID call to action, is value creation and consumerism. I like to think of it as waves and tide. Waves go up and down, and we can be distracted by lots of things that are happening in healthcare, but the value proposition that the industry just has to get better at delivering better outcomes at lower prices is like the tide coming in. It's not changing, and it's relentless. So what's a provider supposed to do about it? Far-sighted organizations, and I include Intermountain Healthcare in this group, they recognize that they got to change, right? So Mark Harrison, the CEO at Intermountain, likes to make the statement, the very profound statement, that healthcare isn't becoming unaffordable. It is unaffordable. So the right provider response is to realign the way that the companies organize themselves to deliver on the promise of right care, right time, right place, and right price. And increasingly, I believe the future will belong to platforming companies that in an Amazon-like way knit together the capabilities necessary to deliver great outcomes at great prices with great customer services. And they will do that through strategic partnerships. They will reconfigure routine care. They'll get particularly the commodity care, which is probably 75% of care that's delivered. We'll decentralize, we'll go to lower cost, more convenient settings. And there'll just be this intense managerial focus on increased productivity and effective revenue management. I like to think of the Ben Franklin quote from Poor Richard's Almanac, a penny saved is a penny earned. So companies that can deliver the same or better healthcare for less money will make more themselves and deliver greater value to customers. In the same way, capturing $1 of revenue that otherwise wouldn't fall or wouldn't get captured is also a penny saved. So the combination of those two things, even before COVID, were remarkably important, needed to differentiate on service and value, and there was no time to waste. And then, of course, came COVID-19. I'm going to stop here for a second and before we get into part two and see if there are any questions, and I'll turn it back to our most astute moderator, Dave Burda.
Thanks, Dave. Before we move on to the second half of your presentation, I do have a question for you, and that's, you identified 5, I think you call them pressure points on margins. And, as a journalist, I'm always interested in ranking what's top, what's bottom, right? So if you were to rank those 5 before COVID and then rank those after COVID, what would be on top, and would that ranking change?
Dave, I've never thought of you as a listicles kind of guy, but a good question. I would say the most important pressure is that combination of more disciplined purchasing and changing consumer behaviors. As I said in my remarks, demand-driven change, superhero results. And I think as buyers change what they're demanding from the healthcare system can't do anything but adapt to that. To do so otherwise is to risk the fundamental business in which they operate. This actually sounds like an extreme position, but this is the pressure every business that operates in a normal market environment operates within. there is no business without customers. Healthcare has always been a bit of a funny business because people like you and me go to the doctor tells us what to do, we do it, and then somebody else pays for it. So the signal between buyer and seller severs, and there isn't the ability for the providers to adapt to what the consumers need. And I think that is going to change in fundamental ways. I also believe that with all of the technological advancement that we're seeing, the locus of the industry will shift from payers and providers, suppliers, to consumers in these platform-like companies, and therefore meeting and solving, identifying consumers' jobs to be done, fixing them when they're broken, keeping them healthy, sustaining and enhancing their health will become what the services health companies need to provide in order to win consumer trust and purchasing. And so I would say that's where the force is coming from primarily. And you could put governments in there as a more disciplined buyer, then the competitors and the regulatory environment aligning to make that force even stronger.
Got it. Great. Now, why don't we move on to the second part of your presentation, which you call after COVID-19 or AD, and I'm just curious what the AD stands for. Is that after death, after Dave? What are we talking about here?
Well, actually, neither of those. And I was clearly I was clearly going for a biblical reference. It really stood for after disease. So after the COVID-19 passes, what's left? I mean, the industry's still going to be here. We're still going to have people needing healthcare. So what does that begin to look like? So let's talk about COVID-19 and the last 3 months. These numbers are just staggering. In 1921, T.S. Eliot wrote the poem "The Wasteland," and he wrote it right in the wake of World War I, and then the great influenza that we're now up, being compared to, which killed as many as 50 million people worldwide. Death was all around, and the first lines of that poem are, "April is the cruelest month, breeding lilacs out of the dead land." And I think about the month of April and what our country went through. I mean, just look at these numbers. We had 89 cases and 2 deaths in March. And by mid-May, by now, we've gone to over 1.5 million cases, and it's probably much higher than that, and 90,000 deaths, and that's probably higher too. Unemployment, which has been very low for years and hovering in the mid-3s, with, as of today now, 38 million people having applied for unemployment insurance in the last 6 weeks. We're looking at estimates of unemployment being at Great Depression levels, so 25% or so. There's been broad system failure in our response to the crisis. If you look at how supply chains worked, how data flowed, but even more than that, it's revealed the real fault lines in the system, because the groups bearing the brunt of COVID-19, and this will come as a surprise to no one, are the elderly, who constitute about 1/3 of the deaths, over half the deaths in some states, and those that are already sick, that are struggling with chronic disease, and that falls disproportionately on low-income people. The failure of our system to manage and improve the health has been apparent for a while. When you look at things like the death gap, life expectancy gap between those in affluent neighborhoods and those in low-income neighborhoods. But COVID has just brought that out into the full light of day. Meanwhile, the government has undertaken just massive amounts of debt to cover stimulus. I'm having a debate with myself, trying to decide if I'm more worried about inflation, because we seem to be able to print money without limitation, or deflation, because oil prices, for example, are at record lows, and they're usually a leading indicator of other commodity related activities. And so, managing this from a fiscal and a monetary perspective, I think, is remarkably challenging. And so that's happening, but it's going to be very clear that there's not going to be as much money going around when the dust settles, which will put enormous pressure on healthcare to become more efficient. Meanwhile, the demand profile of healthcare also seems to be changing. I mean, it's too early to tell, but I had a conversation last week with one of the C-suite employees for one of the big New York systems and New York City systems, who had was trying to figure out where have all the patients gone. It reminded me of that anti-war song from the 60s, where have all the flowers gone? I mean, they're not coming to the big hospitals. They're not coming to the EDs. They're not coming to the doctor's offices. How much of this is just kind of people reluctant to go outside and engage, and how much might be a fundamental change in demand patterns, toward virtual, toward more convenient urgent care centers, and so on. And then in April, again, the cruelest month, 1.4 million healthcare workers laid off, which seems totally counterintuitive to me, given that we're confronting our worst healthcare crisis in over a century. So that's COVID. COVID is overwhelming now, but it is taking place within a whole host of other forces that are going on. Some of you may remember Tom Friedman's book from a couple of years ago, Thank You for Being Late, Thriving in an Age of Accelerations. And he has a chapter in there, something to the effect of what the hell happened in 2007. And he describes a form of technological convergence that's really almost unparalleled in human history. The iPhone came out, Facebook went global, Twitter became a company, Google bought YouTube, Amazon released the Kindle, cloud technologies came online, Moore's law on capacity and computing power just continued to expand. And this really launched the smartphone era, which we've become very accustomed to. And one way to look at this is just 1G, 2G, 3G, almost sounds like a child's song. And so in 2007, we were at 3G, and we were just on the verge of launching into the gig economy, and with apps and so on. And one way to think about this is under 3G, each Wi-Fi spot could connect to about 250 devices. That went to thousands of devices with 4G, which is why we're so much more able to stream content and engage in virtual commerce. We are right on the cusp of 5G, which will take that thousands and go to millions. So in the future, and by future, I mean, within the next 2 to 3 years, everything will be talking to everything else. Your toothbrush will tell you when you're sick in the morning. I halfway think your toothbrush, if it's connected to all this other data, could probably figure out whether or not you have COVID. Who will tell? So I actually believe we're on another type of grand convergence, 15 or so years after 2007, where the just ubiquitous connection and instantaneous response of 5G combines with all of the new types of analytic power to fundamentally change life as we know it. And so how is that going to hit healthcare? We're already seeing that in a way. We're on a Zoom chat right now. I run with a guy that put Zoom in at the University of Chicago last year. And on March 8th, they had 300 Zoom hours. And on April 8th, 1 month later, they had 1.9 million. So these technologies not only scale, generally they scale massively very quickly. And so we're seeing that, how much healthcare in the future goes virtual. We've seen much greater regulatory flexibility. Probably the most important there is allowing people to practice at the top of their license. And health systems are able to do so much more when that happens, relaxing some of the cross-border regulations. And I just don't think that goes back in the bottle. So you get new care models, you actually get new business models that fundamentally change the way we do things. Better, faster, cheaper has never been more relevant. And I also think we're going to see much more the emergence of human-machine collaboration. There's a company called Zipnosis in Minneapolis that does asynchronous virtual care. Most virtual care just replicates a doctor's visit. So Teladoc, the average time for a televisit is 18 minutes, replicates a doctor's visit on virtual. But what Zipnosis does is they use bots to walk through the 90% of cases that are routine and can be addressed with logic trees. They get to a diagnosis and a suggested prescription. At that point, they go to a human being who takes a couple of minutes to review it and either give it thumbs up, modify it, or go in a new direction. And the ability to do that, something that takes 2 minutes versus 18 minutes with machine aid is remarkable. So Zipnosis did 700 of their teleconsults on March 9th. On March 21st, they did 98,000. Also under 5G, latency goes down to 8 milliseconds. That's basically the same amount of time that it takes a human being to see something and interpret it. So with 5G, we'll be able to have a surgeon operating in California via robotic controls on somebody in Chicago or really anywhere in the world, and it'll feel like real time. So world's changing. COVID has upended healthcare and pretty much everything else. Thank goodness we're all in healthcare because we need healthcare. I'm personally glad I'm not in the commercial real estate business right now. But having said that, the pace of acceleration is going to change, so velocity is going to increase. Just physics, velocity grows or shrinks as a function of acceleration, and if acceleration is increasing, velocity of change will also increase. So if you're a health system and you're looking at this, the COVID crisis in the moment, and then these technological breakthroughs that are going to change the way we do everything the same way that the smartphone did in 2007, you need to have a new way of thinking about crisis management. Rahm Emanuel, our former mayor, I live in Chicago, said, never waste a crisis. So the trick is to do things today that help you solve the COVID crisis, fight the war, but then also position your companies for winning the peace, which is delivering value-based care. And I think Pete McKenna at Baylor Scott and White kind of captures this exceptionally well with these two quotes, and I'll read them. It talks about their recovery plan has two elements. The first is to regain the lost volume by offering compelling services to our customers. The second is to address our cost structure in fundamental ways that improve outcomes and increase value. Expect to see more virtual care, augmented intelligence, and rigorous back office optimization. So back to that, emphasis on the strategies, greater productivity, revenue management, decentralization, and so on. And then talking about virtual care, they saw their virtual care more than quintuple in a period of 3 weeks. We had this elastic demand, so basically unlimited demand for e-visits, but didn't have enough providers to cover them. At the same time, clinic visits were down. Providers had time in their hands. We quickly trained them on our virtual care platform, by the way, using YouTube videos, and more than tripled our e-visit capacity within 36 hours. So that's an idea, I think, of this crisis, forward-looking crisis management that's so essential. Is you got to fight the war, but you can't do it without simultaneously having a sense of what you want to look like afterward. And I personally believe when we look back at this period of time, it's going to be the period where we say that healthcare rediscovered its soul. I mean, it's hard not to look at what frontline workers have done, the risks they've put themselves on, the hours that they've worked, and so on, the incredible dedication and accomplishment, and not be moved by that. At the same time, the business of healthcare is largely, I won't say largely, but in many ways has failed those remarkable frontline workers. We need to make their lives easier and better so they can make our lives easier and better. So I'll end with this concept. I'm co-writing a piece right now with former Governor Mike Leavitt, former HHS Secretary Mike Leavitt, with the title of "With Roses or Pitchforks, How Will Consumers Greet Post-COVID Healthcare?" And with roses will be like we're describing here at Baylor Scott and White, you know, basically a better product, consumer-centric, focused on meeting needs, getting more efficient, really delivering on the promise of value. Pitchforks will be the frustration with the system and the budget pressures and so on become so overwhelming that they manifest themselves as bad public policy. Medicare for all, rationing, price controls, burdensome regulations, more rigorous oversight, and essentially healthcare will hand its future over to external agencies. So I think it's really now or never for value-based care, and it's incumbent on all of us that believe in market-based healthcare to step up right now and really honor the work of frontline care workers by delivering the business systems that really support value and allow them to do what they really want to do, which is solve the needs of American consumers in healthcare. You know, our motto for Foresight Health is outcomes matter, customers count, and value rules. And pretty much everything we talk or write about, including today, falls into that bucket. But I'm also wanted to talk about this first quote, and I steal the format of it from Reinhold Niebuhr, who wrote about democracy, that humankind's capacity for justice makes democracy possible. Humanity's tendency toward injustice makes democracy necessary. So you get this balancing of good and bad. And I think healthcare confronts the same type of dual challenge. You know, the industry's capacity for innovation makes value possible. Its proclivity for waste makes value necessary. So now more than ever, it's always been important, but now more than ever, healthcare needs to deliver on the value proposition. And quite honestly, if the industry doesn't do it, you know, others are going to take its destiny away from it. So it's time for us to collectively step up and address the challenge. And Dave, I will stop there and take any questions.
Sounds great, Dave. Thank you. Let's go right to them. You know, my job is to keep us on time. We've got 5 minutes left. So here's number one. Where should organizations focus when looking to cut their operational costs?
Well, the big three on the business side are financial, accounting, supply chain, and human relations. And unfortunately, health systems and the industry as a whole has managed each of those in a silo way and hasn't optimized across segments. So I would be looking at ways to make the business operations as holistic and integrated as clinical operations are becoming. And oh, by the way, that really can't happen without rigorous cost accounting. So understanding costs is the first step in getting control of expenses. And until you understand your costs, you really can't deliver on value.
Got it. So know what your target is before you shoot, right?
Very well said.
Okay. Another question. What types of technologies should organizations invest in going forward?
Well, I would say, the goals are pretty clear that, you want to drive better outcomes, lower costs, better customer services. So technologies that enable the type of data sharing and then the analytics on top of that to drive information to frontline professionals, whether they be in clinical care or business, that we can optimize performance. And that's part of what I'm thinking about when I say that the future belongs to platform companies. So I would be investing in technologies. A lot of them will be data driven, but also finding strategic partners and capabilities that allow me as a large health system to knit together what we need to truly meet consumer needs and have that type of digital exchange that receives information, analyzes it, pushes it back, and then delivers what consumers need. In the same way Amazon does today. We know how to do this. It's complex in healthcare, but it's not impossible. And many companies are already beginning to start doing that.
All right. Here's one more. It's a statement wrapped inside a question. All right. Many providers seem unwilling to commit to telehealth and other consumer-oriented technologies in the long term, based on the murky reimbursement picture. What kinds of regulatory and payment incentives are going to be needed to encourage health systems to embrace these tools to connect with patients?
Well, I like to say that we're not going to change the way we deliver healthcare until we change the way we pay for healthcare. And I think that's right where the questioner is going. Part of the reason we've seen the explosion in virtual care is that CMS came out and came up with a code for it, so they're paying for it. I think longer term, we're going to see the types of full risk models emerge that make it incumbent on health systems to reorganize to manage risk. So imagine full risk bundles with guarantees for episodic care like hip replacement surgery. I think we're going to see more and more of that for definable conditions. And then the flip side of this, and we see many examples of this that work exceptionally well. They just aren't a huge percentage of the business yet, but where a company takes the full care risk after some adjustment based on a monthly payment. They get a monthly payment per member per month, and then they manage the care of people after that. And I love those models because they align the patient's needs with the company's needs. It's always better to prevent a disease than it is to treat one. Places an emphasis on prevention, on chronic disease management, on integrating mental health and physical health services, and on engaging not only individuals but communities in their health. So I believe the payment models are shifting that way. The industry resists it, but I do think the enlightened companies will understand that this is where they need to go, and will start, and are already starting, in the same way you saw Pete McKenna at Baylor White articulating that, are already starting to force their organizations to embrace value in much more fundamental ways.
Okay, one more. You mentioned reconfiguring care earlier. Any suggestions for safety net providers who may not have the same sort of financial ability or legal responsibility to just do whatever they want? Any thoughts there?
Well, as I said, COVID-19 revealed an already known truth that lower income members of society at much greater risk for chronic disease, shorter lives, and obviously COVID-19. I believe ultimately the solution is better community-based care. And I think the safety net providers in partnership with state health agencies and other types of sort of health-oriented organizations need to think very hard about how do we align resources in ways that deliver the best outcomes overall. So, Oak Street Health here, which works with dual eligible people, Oak Street Health. They're in several cities, but they started here in Chicago. In a period of about a month, they switched from entirely in-clinic visits to entirely virtual care visits. And they're calling their members, their patients, several times a day, checking in on them. They're delivering food and so on. They don't have to worry about a payment because their payment's already coming in. So I would say for the safety net providers, and this isn't going to be easy, but we need a new plan of attack. It just can't be spending more monies on acute care facilities without making much better investments in community-wide health, social determinants of health, and so on.
Well, thanks, Dave, and
Yeah.
thank you everyone for your questions. Also, if you'd like to schedule a call to talk to Dave about what's happening at your organization, drop us an email at info@foresighthealth.com. That's all we have time for today. Thank you, everyone. For Dave Johnson and all of us at Foresight Health, I'm Dave Burtis signing off. Thank you.